is Pradeep Pendyala, Professor of Anesthesiology. Today I am going to discuss with you the anesthetic concerns in a burn patient. Really you might be getting, but you should know how to manage burn patients. Very essential. Superficial burns are normally first degree burns and partial thickness burns are second degree burns. Full thickness burns are normally third degree burns. And I'm sure you know the percentage of body surface area, how to calculate how much total body surface area have been burned by the rule of 9. Head and neck, 9%. Upper limb, 9%. Lower limb, 18%. And left lower extremity, 18%. And perineum 1%, anterior trunk 18%, posterior trunk 18%. Central nervous system changes would be there in every burn patient, and the cause is nothing but burn per se and hypoxia. There could be electrolyte and metabolic disturbances. There could be carbon monoxide poisoning due to burns, and cardiac output usually decreases. There could be ST wave changes, atrial fibrillation, and arrhythmias. And SV are normally increased, systemic vascular resistance. Renal function is also impaired in most of the burn patient, and increased catecholamine would be there in the blood levels. And GFR is normally increased. There could be hemoconcentration and coagulopathy due to massive blood loss following burns. There could be anemia and thrombocytopenia. These are normal things which occur along with burns. And there could be compartment syndrome in the abdomen because of burns. And salbutamol albuterol reduces inflammation and causes bronchodilation. And you should always remember that there could be hyperreactive airways and bronchitis, most of the burn patient. And when you are planning to intubate such patient, invariably there will be difficult intubation. Awake intubation with fiber optic bronchoscope with topical anesthesia and mild sedation is the safest option. Nasotracheal route preferable, and tracheostomy if you could do early tracheostomy, that will be added advantage. Such patient need prolonged ventilation. Release of contracture from the neck. You have to use local anesthesia and should be done before securing the airway. Common sense. Avoid succinylcholine in most of the burn patient. And the problem is that even there could be resistance to non-depolarizing drugs. As far as possible, there could be always possibility of proliferation of extrajunctional acetylcholine receptors, and that could cause hyperkalemia. Hence, succinylcholine should be avoided after 2 days, and many people say even up to 2 years should be avoided. And as I've said, increase resistance to non-depolarizing drugs. So you have to give increased doses to achieve the adequate muscle relaxation. And fluid resuscitation, normally we used Parkland formula for fluid resuscitation. Debridement of major burns can cause a lot of blood loss. Preferably rotan. I'm sure you know what is rotan. Rotational thromboelastometry and thromboelastometry, TEG. These are the point of care testing coagulation and hemoglobin should be instituted. And burn patients are normally can have VTE, and you have to take VTE prophylaxis, venous thromboembolism prophylaxis. Pain control is big problem. Normally steroids and not steroids, NSAIDs, paracetamol can be given, or for major burns, naturally the opioids will have to be given with PCA, preferably patient control analgesia. Ketamine is very, very useful in airway management in burn patients. It's a very strong analgesic too. And you must know about tumescent anesthesia, that is the release of contractures of the neck. You use sometimes tumescent anesthesia when everything is contraindicated, nothing is being possible. In this, incidentally, the maximum safe dose of lignocaine goes to 35 to around 40 milligram per kg body weight. Huge. But what you have to do, you have to do subcutaneous infiltration of large volumes along with saline and epinephrine, 1 in 10 lakhs. And lidocaine should be diluted to 0.05 to 0.1% to cause swelling and firmness locally. That can cause local anesthesia toxicity, but normally after 12 to 14 hours following injection, because epinephrine affects LAS, which causes vasoconstriction. So the toxicity could occur much later. Thanks for patient listening. Have a wonderful day, Colonel Pradeep Indiala. Until next time, take care. Bye-bye.